Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing parenteral nutrition. The reason we are discussing parenteral nutrition today, or PN as it might be called, or TPN, is because parenteral nutrition is important as it may be used as a route of nutrition support for patients who cannot tolerate enteral nutrition, and this includes the oral feeding route as well as tube feeding. Particularly for patients who do not have functional gastrointestinal tracts. As a pharmacist, it's important to be aware of parenteral nutrition indications, parenteral nutrition routes, complications from parenteral nutrition, and compatibility and administration issues related to parenteral nutrition. So our objectives today will be to discuss and describe components of parenteral nutrition, or PN, identify indications for parenteral nutrition, classify parenteral nutrition access routes, recognize complications of parenteral nutrition, discuss compatibility, interaction, and administration issues associated with PN. And then in a few days in class, we will then prescribe appropriate parenteral nutrition formulas based off of the information presented in today's talk. So we're going to start off with a patient case. FM is a 57-year-old female. She's 5'5" and 55 kilos, presenting to the emergency department with recurrent nausea and vomiting. She was diagnosed with Crohn's disease about 6 months ago. Over the last 2 weeks, she's reported feeling weak as a result of poor oral intake, secondary to her nausea and vomiting symptoms. Abdominal scan findings demonstrated a small bowel obstruction. A PICC line, right peripheral IV line, and a nasogastric tube were placed. Currently, FM's vitals are within normal limits. So question 1, which type of nutrition is most appropriate for FM to receive? Oral nutrition, enteral nutrition, or EN, peripheral parenteral nutrition, or PPN, or central parenteral nutrition, or CPN. The second question is, when is it most appropriate for FM to receive the nutrition support modality selected in the first question? Is it appropriate for them to receive that nutrition support modality immediately, within 24 to 48 hours, within 7 days, or within 10 days? And question 3, what is the most likely complication of the type of feeding selected in question 1? Is it abdominal distension, infection, metabolic bone disease, or nausea and vomiting? So after we talk about parenteral nutrition today, you should be able to answer these questions confidently with not only the parenteral nutrition knowledge that you learned today, but as well as the enteral nutrition knowledge that you learned in the last lecture. So in terms of parenteral nutrition, one concept that's very important for parenteral nutrition is understanding energy expenditure. And we essentially referenced this slide before whenever we were talking about macronutrients. But it's also important to remember here for parenteral nutrition. As with parenteral nutrition, we can basically formulate a lot of different formulas based on a patient's macronutrient and micronutrient requirements. So essentially, with parenteral nutrition, we will be using a lot of weight-based equations to generate our calorie needs for our patients. So just keep this slide and a lot of the other slides that you've seen before in mind as you are thinking about parenteral nutrition, because essentially the requirements for your nutritional status for patients is still the same with parenteral nutrition as it is with enteral nutrition, as it is with your macronutrient requirements in your assessment. So the weight-based equations as a result still apply here, and you see that they're bolded, so these are the ones that you need to know for examination purposes. So they are all the same ones that we had in the previous macronutrient vitamins and trace elements PowerPoint. So a little more about macronutrients and fluids specifically. The protein requirements are still the same here. The ones that you need to know were bolded for the purposes of examination recall. The unbolded ones you do not need to know off the top of your head, but you may need to reference in the future whenever we do some of our cases. Fat requirements are still the same here as well. For our purposes, for the examples that we're going to use, we will be primarily utilizing intralipid as our fat emulsion source, as it is probably the most common fat emulsion source in practice. Dextrose requirements are still basically the same as we talked about previously as well. And we will calculate these out whenever we actually write parenteral nutrition formulas on day 7 of the class. This slide is a little bit newer to you. So one thing that we didn't reference whenever we reference macronutrients, vitamins, and trace elements was fluid requirements. And fluid requirements can be dependent on many different factors out there. And there are many different formulas to estimate fluid requirements in both adult and pediatric patient populations. For the purposes of this talk today, we're just mainly focusing on adult patients. Whenever we do talk about nutrition in pediatrics, we will reference the pediatric population and how the fluid requirements are calculated for those particular patients. For purposes of calculating fluid requirements for adults, like I said, there are many different formulas that you can use. Some may use a formula of 30 to 40 mils per kilocal, which is essentially just another weight-based formula. Some may say that once you calculate your calorie requirements, that you give about 1 mil for every kilocal that you are providing the patient. So this is kind of similar to the concept with enteral nutrition of a lot of the enteral nutrition formulas being 1 mil per kilocal or 1 kilocal per mil. So essentially similar concentration if you choose that route. Another route that you can take is you can essentially use a patient's BSA and calculate the fluid requirements based off the patient's BSA. There are many different ways to do it, and depending on your individual patient population, you may have some limiting factors depending on which different formula you choose. You will not need to know the fluid requirement formulas for examination purposes, as they vary widely among different patient populations. What I would advise you to know, however, is patient populations where you may need to fluid restrict patients. So if you think about patients who have congestive heart failure or heart failure in general, so these patients are can be very edematous as a result of low cardiac output that essentially backs up through the different chambers of the heart and throughout the lungs, and eventually backs up to the rest of the body, producing edema. In this case, patients may be edematous and may require a fluid restriction. Patients who have end-stage renal disease, where they may not be able to urinate as much, may also require a fluid restriction. And in addition, cirrhosis or end-stage liver disease patients who do not make sufficient amounts of albumin as a result of liver damage may also require a fluid restriction. So these fluid-restricted disease states may not necessarily follow the standard fluid requirement formulas that you see here. And that's important to know because essentially you have to treat each patient as their own individual case. Each patient is not necessarily dependent on each of these formulas. They may have other factors, as we just mentioned here, that may limit their fluid intake. So now we'll talk about micronutrients again, just briefly. So one additional type of micronutrient that we will include in parenteral nutrition, as is included in enteral nutrition, are electrolytes. And with parenteral nutrition, there are many different electrolytes that are provided. The main ones are sodium, potassium, calcium, phosphorus, magnesium, and chloride. With parenteral nutrition, we have many different products available as intravenous solutions that can be provided in a parenteral nutrition bag. So sodium can actually be provided in 3 different salt forms: sodium chloride, sodium acetate, and sodium phosphate. Potassium can be provided as the chloride salt, the acetate salt, and the phosphate salt. Calcium is typically provided just as the gluconate salt here. And phosphorus may be provided as sodium or potassium phosphate, with a little bit of a caveat. Now, because phosphate is actually dosed in millimoles, to make it equivalent to the other electrolytes, we need to convert our sodium phos and our potassium phos, at least for our sodium and potassium moieties, into milliequivalents so that we can adequately add up the sodium milliequivalents from basically the total amount of sodium that we have provided from our sodium salts. So the way that you convert sodium from millimoles to milliequivalents is to multiply by a factor of 1.33. So here, for example, you have sodium phosphate, 10 millimoles. So that's 10 millimoles of sodium and 10 millimoles of phosphate. To convert the sodium from its 10 millimoles, you just multiply by 1.33, and that will give you 13.3 milliequivalents of sodium. For potassium, it's a little bit different. You have to multiply by 1.47 to get the amount of potassium that you have in millimoles to milliequivalents. So here you have potassium that is 10 millimoles. What you do is you multiply 10 times 1.47, and that will give you 14.7 milliequivalents of potassium. The reason why it's important to convert these to milliequivalents is because potassium salts are generally dosed in milliequivalents except for potassium phosphate, which is dosed, as you see here, in millimoles. It is important to note that you may get potential precipitation with calcium if the millimoles of phosphorus in your PN bag plus the milliequivalents of calcium in your PN bag is a large amount. Typically, the rule I like to use is greater than or equal to 40 per liter in the bag. However, the gold standard to assess this is with calcium-phosphate curves, which we'll discuss very shortly. That will be able to tell you whether or not your calcium and phos in the bag are too much and will have a high likelihood of precipitating. Magnesium is available just as magnesium sulfate for PN administration, and chloride, as we mentioned above, is available as sodium and potassium chloride. So going back to calcium and phosphate curves, this is what a calcium and phosphate curve looks like. So these curves are essentially based off of the amino acid formula that basically makes up your parenteral nutrition bag. Essentially, it forms the base of your bag and forms a lot of the different stability lines that are in your bag. And what I mean by stability lines is essentially it basically governs the stability of your bag, the type of amino acid that you have, as do other factors. Now, when you actually measure the amount of calcium gluconate that you have in your bag in milliequivalents per liter of your total bag, and you compare that to the phosphate concentration that you have in your bag in millimoles per liter, essentially when you graph out these two individual components, they will form an intersection somewhere. So say if you have 10 milliequivalents of calcium gluconate per liter in your bag, that would correlate right here where the mouse is basically hovering around. And if you have 10 millimoles of phosphate per liter in your bag, it will basically correlate with right here. If you go and you form the intersection between those 2 points, essentially you'll get the point right here where this mouse is basically moving around right now. So essentially, the way that you interpret this is a calcium phosphate curve used to determine whether or not your PN bag will have a high likelihood of precipitation. If you fall within the left region, your bag may be compatible whenever you actually judge the intersection of these two lines here. Now, if the intersection of those two lines falls in the right zone here, that is actually what is considered the incompatibility zone. That is where you actually have a high likelihood of calcium phosphate precipitation to occur. And calcium phosphate precipitation can be dangerous as it essentially forms a precipitate that can eventually be infused into your patient, and as a result of being infused into your patient can cause harm to your patient because they're essentially precipitating calcium phosphate crystals that form, and that can hurt your patient. So ideally you want to be on the left side of this calcium phosphate curve here. Some factors that influence calcium and phosphate compatibility include amino acid concentration. So an increased amino acid concentration is better. Typically, our most concentrated amino acid is typically 15%. So ideally, it would be great to have a more concentrated amino acid concentration. Amino acid product composition also governs part of it. So how much pH that amino acid formula is, as well as the phosphorus content that's in those amino acid products, will also govern your compatibility of calcium and phos, because essentially these amino acid products also have hidden phos within them also, that we don't necessarily always account for whenever we're writing a PN formula. And that can actually cause problems whenever you are thinking about calcium phosphate precipitation. And that's why we actually use calcium phos curves that are specific for amino acid formulations here. The calcium and phosphate concentration obviously influences the calcium and phosphate compatibility. So the calcium phosphate concentration within the PN bag, as you see directly on the Y and X axis on this graph here, that is a direct determinant of whether or not your bag will precipitate or not. Calcium salt form, calcium gluconate being preferred. Calcium chloride is not as stable, and as a result may have a higher likelihood of precipitating. If you use calcium chloride in a PN bag, it's usually safer to use calcium gluconate. Dextrose concentration increased being better. So the most concentrated dextrose that we typically have available to us is D70 or D70%, so 70 grams per 100 mLs. The pH of the overall formulation, so kind of going back to the amino acid product composition. The lower the pH, the better off your formulation is, or the more, or essentially the more acidic your overall formulation is, the better off you are. The temperature of the formulation, so lower temperatures tend to be better, higher temperatures tend to be worse. In addition, the order that you mix the different additives can play a role in calcium phosphate precipitation as well. So if you think about how a PN bag is compounded, there are many different components within a PN bag. You have your macronutrient components, your protein, your dextrose, your fat. Particularly your fat if you are in a 3-in-1 PN bag. If you're in what we know as a 2-in-1 PN bag, the fat will be separated out from the dextrose and protein components. If you are compounding a PN bag, ideally for the purposes of preventing calcium phosphate precipitation, what you want to do is you want to separate the calcium and the phos as far away in the process as possible. Because say if you mix your calcium and your phos at the very beginning and you mix them together, they're automatically most likely going to precipitate. Essentially, by incorporating the other components of the bag, like your protein, your dextrose, your fat, if you have a 3-in-1, as well as your other electrolyte components within the bag, essentially that provides volume that will essentially dilute any kind of incompatibility from happening. That's why it's ideal to separate your calcium and your phos when you actually mix your bag together, because you may essentially get these nice little looking crystals here, which are not very nice whenever you infuse them into a patient, and that is what should never happen. That's why it's always also important that you do a visual check of your parenteral nutrition bag before you actually send it up for administration to your patient. So going back to overall electrolytes, we do have overall daily electrolyte requirements that normal patients will require. And essentially, these are the main ones that you see here: calcium, mag, phos, sodium, and potassium. While you don't necessarily need to know these numbers right now, they will be important numbers to know whenever we actually begin to write parenteral nutrition orders, because these will be the numbers that we kind of go off of in terms of determining how much electrolyte to put in our parenteral nutrition bags. So for calcium, we typically aim for a daily requirement of 10 to 15 milliequivalents. For mag, we typically aim between 8 and 20 milliequivalents. For phosphorus, 20 to 40 millimoles is appropriate. For sodium and potassium, they are actually the same requirement, 1 to 2 milliequivalents per kilogram. Now, there are factors that increase your needs that you see here. There are also factors that may decrease needs. For example, for potassium and some of our other electrolytes that are eliminated renally, for patients who have renal dysfunction, it may not necessarily be appropriate to give a patient 1 to 2 milliequivalents per kilogram of potassium, because those patients will not be able to eliminate potassium renally as well as a normal patient with normal renal function would. And as a result, potassium may accumulate. So keep in mind that these are the standard daily requirements for normal patients with normal organ function. These numbers are just roundabout numbers. Essentially, there are a lot of different numbers that you can actually put within your PN bag and still be safe. But you need to make sure that you are also keeping the patient in the back of your mind. And if you have a factor that may increase the patient's needs, in that case, you might want to increase your needs even higher than what you have listed here. But there may also be the restrictions that I mentioned that may preclude you from going too high for some of your patients. Acetate and chloride are other components that we have with our salts. With acetate and chloride, acetate is essentially converted to bicarbonate in the body, and bicarb is a base, so this is needed to maintain normal acid-base balance. For chloride, chloride is essentially an acid in our body, and it is also used to maintain acid-base balance. So whenever we actually write orders for parenteral nutrition, we're going to have to keep acetate and chloride balance in mind for the purposes of acid-base balance. And we'll talk about this a little bit more whenever we actually write the formulas out. So trace elements are still relevant here as they were in our second talk. Again, trace elements basically include our typical 5 trace elements: chromium, copper, iron, manganese, selenium, zinc. It does not routinely include iron. And the reason why iron is not included in trace element formulations is because iron can actually cause the bag or your PN bag to crack or basically separate out. And if your bag separates out, particularly if you have a 3-in-1 solution with fat emulsion, that's the component that will basically be cracking. If that fat emulsion cracks and the emulsion separates, it is not suitable for administration to your patient. So the same trace element considerations still apply here. It's always important to always look at your patient's laboratory values to assess whether or not they need a trace element reduction, particularly if they have a T-billy greater than or equal to 2 to reduce copper and manganese exposure. For renal elimination purposes, we don't really reduce trace elements in regards to renal elimination as a result of patients typically being able to either eliminate with some urine output or if they are getting hemodialysis or some other kind of dialysis like peritoneal dialysis. Vitamins, again, are also important here. So we actually do put multivitamin infusion 12 or multivitamin infusion 13 into our PN bags, and those will actually make the PN bags appear yellow, particularly if you have a 2-in-1 solution. With a 3-in-1 solution that contains the fat emulsion may predominate there and make the bag look white, despite whether or not you put the vitamins in or not. So let's talk a little bit now about general overview of parenteral nutrition now that we've kind of reviewed a lot of the macronutrient and micronutrient components of parenteral nutrition. So essentially, parenteral nutrition versus enteral nutrition is required whenever a patient does not have a functional GI tract. So remember, with enteral nutrition, we had a functional GI tract. So remember, enteral nutrition included oral feeding and tube feeding. If you don't have a functional GI tract, you automatically may have to go to parenteral nutrition. If it is short-term parenteral nutrition, you may potentially administer peripheral parenteral nutrition. And if it's a long-term patient, and whenever I say long-term, I'm saying probably greater than a week or 2 weeks, you may put them on central parenteral nutrition, though that rule is not necessarily hard and fast for central parenteral nutrition. Even if they do require short-term for parenteral nutrition, they still may be put on central parenteral nutrition because central parenteral nutrition doesn't have as many limitations as peripheral does, as we'll talk about in a second. So parenteral nutrition, as we talked about, is typically known as TPN, though parenteral nutrition is the proper term that is used for this type of modality. TPN is typically a term that refers to 3-in-1 solutions. For 2-in-1 solutions, we should be using the term parenteral nutrition. And in general, just to be safe, I always just use parenteral nutrition or PN whenever I'm in practice. So parenteral nutrition is essentially the delivery of nutrients via IV line into systemic circulation. And we have two different types, peripheral and central parenteral nutrition, which is PPN and CPN. Peripheral parenteral nutrition, or PPN, is the delivery of nutrients via a peripheral IV line into systemic circulation. So what makes a peripheral IV line different than a central IV line is that a peripheral IV line is inserted into peripheral veins. So if you think about veins that are distal, that are essentially in your arm or in your wrist, those are peripheral veins. So these veins are much smaller and as a result can only tolerate so much concentration of actual ingredients. PPN is reserved when central access is unavailable and when GI function is expected to return within 10 to 14 days. So this is usually a short-term solution whenever we cannot get a central line established. We'll talk about central line shortly whenever we talk about central parenteral nutrition. Some limitations of peripheral parenteral nutrition that you should note is that it is limited by dilute large volumes to provide nutrient requirements. So if you wanted to provide all of the nutrient requirements that you would want to for a normal patient, you might have to give 3, 4, 5 liters worth of fluid, which is not really feasible for many patients, as many patients might not even take in that much fluid per day. And as a result, patients can become very fluid overloaded and have symptoms resulting from that, such as pulmonary edema, etc. The reason why peripheral parenteral nutrition has to be in large volumes is that it is limited by its osmolarity. Peripheral parenteral nutrition cannot exceed 900 milliosmoles per liter due to the risk of vein inflammation or thrombophlebitis. Because if you concentrate the parenteral nutrition so much and infuse it through that peripheral vein, eventually the vein will become inflamed, and it might be very short occurrence, or short to occur occurrence, where that vein becomes inflamed and essentially might even, rupture because so much nutrition is being given in that peripheral vein. Smaller peripheral veins cannot tolerate very much nutrition. So what does 900 milliosmoles per liter actually mean whenever we refer to the osmolarity limit for PPN? Well, if you actually go through, you can calculate the osmolarity of your PPN based off the different components that you have. So with dextrose, for every gram of dextrose that you receive, you get 5 milliosmoles. For amino acids, it's 10. For fat emulsion, it's 1.3 to 1.5, depending on your formulation. However, a lot of clinicians actually consider this negligible whenever you think about the overall scheme of calculating osmolarity, because some patients may only get 50 grams or less of fat emulsion per day. And as a result, it really doesn't really amount to much. In terms of electrolytes typically are around 1 milliosmol per milliequivalent of electrolyte. So if you think about it, if you give 90 grams of amino acid in your peripheral parenteral nutrition bag, assuming it's a 3-in-1, you wouldn't be able to give any other nutrient, dextrose, fat emulsion, or electrolytes, because you will have already met your osmolarity limit of 900, assuming that that bag is a liter bag. Now, if you make your bag 2 liters, you might be able to double that amount of amino acid that you're giving and give 180 if your patient requires that much protein. However, again, it's limited by the amount of fluid that you give. You don't need to necessarily know these osmolarity numbers off the top of your head. You just need to be aware of the osmolarity limits for PPN and for CPN. You don't need to know these numbers to calculate the osmolarity. If you do need the osmolarity, we will give you the osmolarity on an exam, for example. Central parenteral nutrition is a lot different than peripheral parenteral nutrition. For central parenteral nutrition is delivered via a central IV line into systemic circulation. And this is the preferred route for parenteral nutrition delivery. It's usually reserved for patients whenever they require PN for ideally at least 7 days, and that can be longer, and that even is indefinitely in some patients, particularly some of our short bowel syndrome patients who may require PN lifelong. A central line is necessary for administration of central parenteral nutrition, just as the name says. This is commonly established by using a PICC line or a peripherally inserted central catheter. Basically, how this catheter is inserted is it is inserted into a peripheral vein, and then the tip of that catheter is actually routed up all the way up to this location up here called the superior vena cava. And this location is essentially where most of your blood will actually flow back to the heart from the rest of the body. You also have your inferior vena cava where some of that blood flow also flows back. The point of contention here is that essentially, because you are infusing into the superior vena cava, there is just so much blood coming back that it basically will dilute everything down. So as a result, you can basically infuse as much macronutrients as you need to in a parenteral nutrition bag or central parenteral nutrition bag, because it's just so dilute here within the superior vena cava. And as a result, because of all that blood flowing there, it is not limited by osmolarity. So basically, the rules that you saw here in terms of calculating the osmolarity limits for peripheral parenteral nutrition do not apply for central parenteral nutrition. As central parenteral nutrition is given through large central veins that are very dilute. And typically, those tips of the catheters will terminate in the superior vena cava here. Another form of central IV line access is an implanted port. These ports are typically placed somewhere in the upper chest area. Typically, these implanted ports are typically reserved for patients who are getting chemotherapy, but it is another form of a central line, and as a result, can be used for administration of parenteral nutrition, particularly central parenteral nutrition. And then the other form of central line that we have is a tunneled central venous catheter. These catheters can be routed in a variety of different areas, such as your internal jugular, which is essentially in your neck, or your femoral, which is down in your leg area, your leg thigh area. Tunneled essentially just means that there is special protection with this catheter in terms of essentially causing an infection, though it's not necessarily foolproof for these tunnel catheters, as because these tunnel catheters are essentially still being inserted through the skin into the patient, and that always has an infection risk associated with it because our skin contains many different bacteria, particularly staph and strep. So just to reiterate here, peripheral parenteral nutrition is essentially inserted into a peripheral vein, which is much lower down here. These are the smaller veins, and it is limited by osmolarity. Your central parenteral nutrition is not limited by osmolarity, as it typically is inserted into a central vein, or is inserted peripherally, such as a PICC line, and then routed up into a central vein area like the superior vena cava, which is an area that essentially dilutes blood down so much it doesn't matter what the osmolarity of that solution actually is. There's no limit to it at that point. So that's why central parenteral nutrition is preferred over peripheral parenteral nutrition. As one of my colleagues and former mentors essentially said, essentially peripheral parenteral nutrition in some cases is like a couple of candy bars in terms of the amount of calories that you can provide adequately with the amount of fluid. In a lot of cases, you won't be providing more than 1,000 calories with peripheral parenteral nutrition, and that does not really meet the nutrition needs of many of our patients who might require 1,500 plus kilocalories per day. That's why we give nutrition centrally. So some indications for parenteral nutrition in general. So this can be either peripheral parenteral nutrition PPN or central parenteral nutrition CPN. Parenteral nutrition is given to patients who do not have a functional GI tract or cannot meet the nutritional requirements for enteral nutrition alone. So essentially you have to have some kind of problem with your GI tract where your GI tract is not able to properly absorb or function to absorb the nutrients from enteral nutrition, including tube feeding and oral feeds. The other way that you might get parenteral nutrition is if your patient is not able to tolerate their goal enteral nutrition requirements. So, for example, if a patient does not meet their goal tube feeding rate, say if their goal tube feeding rate on the formula that you chose is 50 mils per hour, and they're only able to tolerate 20 mils per hour because they might get nauseated and vomit, either you might need to change the enteral nutrition formula to something that may be a little bit more tolerable for them, or you might actually need to supplement them with parenteral nutrition. So some possible other indications for parenteral nutrition other than lacking the proper nutrition from enteral nutrition include small bowel resection. So if you have part of your small bowel resected, particularly with our patients who eventually then go and develop short bowel syndrome as a result of that bowel resection, you may require parenteral nutrition for some time, or even potentially life, depending on what part of the bowel gets resected. And we'll talk about small bowel resections a bit more whenever we talk about nutrition in gastrointestinal disorders, and when certain resections will cause patients to be on parenteral nutrition for life. Ileus is another potential indication. So ileus just means a slowing down of the bowel to where the bowel is not essentially moving forward and is not undergoing normal peristalsis. So because the bowel is not moving, that is an indication that food may not properly absorb and get processed in your bowel, and that might be an indication for PN therapy. If you have intractable nausea, vomiting, or diarrhea on enteral nutrition, you might be a candidate for parenteral nutrition. A lot of times this can be remedied by placing the enteral nutrition terminating instead of the stomach. You might actually have it terminate in a later area of the bowel, such as the duodenum or the jejunum. However, this isn't done a lot typically in practice. We do see commonly that enteral nutrition is typically nasogastric, though you may be able to basically put insert the tube more distally into the GI tract for tolerability purposes. Bowel obstruction is another problem that can potentially occur. So this can be an obstruction of any sort. It can be an obstruction of stool. It could be an obstruction of another foreign object that's swallowed within the bowel. It can be a variety of different things, but if you have an obstruction, basically contents of the bowel will not be able to move forward. GI fistula, or GI fistulae, the plural form, is another form of a GI disorder where essentially you have a disconnection occur in your bowel that causes leakage of the bowel contents out to particularly an interstitial space or essentially a peritoneal space. And as a result of that leakage of GI fluid, you might actually lose nutrients. So particularly if fistula or fistulae have high outputs, where they are basically expelling liters upon liters of fluid, that can be a potential problem, and that might be a reason to give nutrition parenterally instead of enterally. Volvulus is another big type of parenteral nutrition indication. It is essentially the twisting of the bowels, and that's actually what you see here. Here, this is an abnormal twisting of the bowel that you see on this scan right here. And it typically will look somewhat like a mass. Essentially what happens is you have a little bit of a twisting of certain parts of the intestine to where, like a water hose, the intestine becomes kinked. If you twist a water hose, for example, and you twist it such that you basically form a kink in the water hose will not flow forward. The same concept happens with the contents of the bowel here. And that is essentially what volvulus is. Chyle leaks, including chylothorax and chylosocites, is essentially a leak of a fluid called chyle into, or actually from the lymphatic system into another part of the body, depending on the location of that area. Typically, this happens post-surgery. It has a low incidence of occurring, but whenever it does occur, that chyle actually has a lot of nutrients in it that can leak out and basically cause your patient to become malnourished. Severe pancreatitis may be another potential indication for parenteral nutrition. However, enteral nutrition should be trialed first per the pancreatitis and nutrition guidelines, essentially. Cancer may be an indication for parenteral nutrition if the patient is not a candidate for enteral nutrition. Remember, you should always trial enteral nutrition first, unless the patient cannot tolerate it. And then Crohn's disease or ulcerative colitis, if the patient is not a candidate for enteral nutrition. So if they're not able to properly absorb the enteral nutrition, or if they have significant nausea and vomiting associated with the Crohn's disease or ulcerative colitis, they may be a candidate just to go straight to PN. and that's perfectly fine. So our PN components, essentially, like we talked about earlier, consist of our macronutrients, so protein, dextrose, and lipids. Like I alluded to earlier, depending on where you have the lipids at, if they are separated from your dextrose and amino acid formulation, is essentially considered what is known as a two-in-one formulation, as you see here within this picture. So the lipids are separated from the dextrose and amino acid component. This is a two-in-one. If your lipids are mixed all together with your dextrose amino acids and electrolytes, it is considered a three-in-one solution. So 3 macronutrients in one bag versus 2 macronutrients in one bag, as you see here. It's important to note that any time that you have fat emulsion always requires a 1.2 micron filter to be placed with the line. And this is essentially to filter out any impurities of the lipid emulsion, and also to minimize things such as precipitation from entering the patient if something precipitates out, in addition to any kind of microbes that may be associated with the lipid emulsion. Particularly the one that we think of with lipids is fungus and fungemia. That's basically what puts the patient at the highest risk of infection with lipid formulations. So anytime that you have a lipid formulation, always use a 1.2 micron filter, whether it's a 3-in-1 solution or the fats on its own is a 2-in-1. Now, if you are administering a 2-in-1 bag with the dextrose amino acids and electrolytes in it, then in that case, for this bag, you'll use a 0.22 micron filter for the dextrose amino acid bag. And you will use a 1.2 micron filter for the fat emulsion. So you're essentially, if you have a 2-in-1, you're using 2 different filters if you're giving lipids on the side. For a 3-in-1, you only need 1 filter. For a 2-in-1, you need 2 filters. The way that you remember these numbers, essentially the way I think about it, is that for 2-in-1, it's always a 2.2 micron filter or a 0.22 micron filter. So the number 2 is the predominant number here. And that is always the case. Otherwise, you just need a 1.2 micron filter, which is basically for your lipids. And the way I remember it is 1 plus 2 is 3. So basically 1 plus 0.2 is equal to 3, more or less. And not directly mathematically, obviously, but you kind of get the picture of what I'm talking about. So parenteral nutrition includes our macronutrients. Lipids always have to be filtered, as well as our protein and our dextrose formulations. We also have micronutrients in the back, so that includes our electrolytes, our trace element formulations, so basically MTE5, and then our multivitamin formulations, which can be MVI12 or MVI13. And then we might also have other components within our parenteral nutrition bag. Some institutions actually allow the formulation of regular insulin to be put in the PN bags as a way to minimize hyperglycemia, particularly for patients who are diabetic or have a reason to become hyperglycemic, such as metabolic stress. Typically, we give around 10 units per every 100 grams of dextrose for patients who develop hyperglycemia in the PN, within the PN bag itself. We can also give the insulin on the side, typical sub-Q administration, but you also have the option of doing it in the PN. And you might also place other medications within the PN bag, including PPIs and H2 blockers. The ones that typically come to mind here, for PPIs, it's pantoprazole. For H2 blockers, it's famotidine. So when do you start parenteral nutrition on a patient? So PN may be initiated assuming that enteral nutrition is contraindicated or may not meet the patient's maximal needs, and a patient has been NPO for 7 days. Now, this assumes that your patient has had normal nutritional intake up until the point where they became NPO. And the reason why we wait 7 days is because parenteral nutrition obviously has high degree of risk associated with it, particularly with infection. Anytime that you place a line into a patient, particularly a central line, and remember central lines are preferred for parenteral nutrition, anytime that you place a central line into a patient, you are essentially inserting potential bacteria with the line insertion there. So line care is going to be very important for these parenteral nutrition patients. If parenteral nutrition is actually indicated. That's why we actually will wait for 7 days to give parenteral nutrition, assuming that your patient is healthy prior to NPO status. Now, obviously, infection is a big risk. However, if your patient is severely malnourished and does not qualify for enteral nutrition or is not getting enough enteral nutrition to meet adequate nutritional needs, you can start PN immediately. So basically, the way I think about it is if you have any degree or a significant degree of malnourishment, then essentially you can basically start any type of nutrition immediately, either enteral nutrition or parenteral nutrition, depending on if you have a functional GI tract. So basically, if you have a malnourished patient, the answer is always to start it immediately. If you don't have a malnourished patient and the patient cannot tolerate EN, it's wait for 7 days first. And yes, that sounds kind of ethically alarming that you would potentially starve a patient, but whenever you look at the risk-benefit profile of giving parenteral nutrition to a patient who basically, is not malnourished, they actually get a higher risk, or essentially the risk is much higher than the benefit is at that point. Because say if your patient is only going to be NPO for 3 days, is it really worth putting that patient at an infection risk to feed them for the 3 days? Clinically, they're not going to be really affected that much by having them be NPO. Versus for a longer period of time, obviously they will be at a higher risk, and that's why we usually wait for that 7-day cutoff to occur before starting parenteral nutrition for healthy, well-nourished patients. Now, whenever we think about severely malnourished patients and giving them parenteral nutrition immediately, some of the factors we look at are the factors that we looked at whenever we talked about nutrition assessment and screening. So if they meet any one of these criteria, such as a BMI less than 18.5, reduced energy intake, or a significant amount of weight loss, particularly if it's unintentional, that might be a red flag for us to assess the patient a little bit closer to determine if we can consider the patient malnourished and start parenteral nutrition immediately. So anytime you have a malnourished patient, always start immediately. If you don't have a malnourished patient, depending on what route you have available to give, whether it's functional GI tract, you give enteral. If it's non-functional GI tract, give parenteral. Some complications that you can develop from parenteral nutrition involve a variety of different things. So you might have improper catheter positioning. Similar to the catheter positioning that you have with enteral nutrition. So whenever you insert a central line into a patient, usually it has to be someone who is very well trained to insert that central line, because obviously the anatomy of larger bore veins is very complicated, and obviously you have to route that peripheral line up significantly as a pick to get to the SVC. And as a result, typically only physicians will do it, though sometimes other healthcare practitioners, such as nurse practitioners, may be trained to actually insert a central line. That is why we always confirm placement with a chest x-ray, as if this line actually terminates in a location where it's not supposed to be, like in another organ like the lungs, for example, if it's routed too far, it can potentially kill the patient. Because macronutrients are involved with PN, hyperglycemia and hypertriglyceridemia are always an issue with patients. As we talked about, infection risk is very big with parenteral nutrition as a result of placing a line in. It's very high risk compared to enteral nutrition, which actually can help stimulate your immunity, though enteral nutrition, like we said, can potentially increase risk of aspiration pneumonia in your patient. Refeeding syndrome is again a problem with any type of nutrition. Anytime that you give dextrose to a patient, particularly if patients are malnourished and begin feeding, you essentially start stimulating glycolysis as well as all of your other metabolic pathways, and those metabolic pathways, even downstream, will utilize a lot of electrolytes. To make ATP, you need phosphorus and phosphate, and that's why we see these patients who start getting fed, who've been malnourished, develop hypophosphatemia particularly. You may also develop PN-associated liver disease over a significant amount of time. Typically, this occurs usually over the course of greater than 1 month in most patients that develop PN-associated liver disease. And essentially, the reason why is because your liver is having to break. Your liver plays a role in metabolizing a lot of your different macronutrients and micronutrients. And if you are feeding a patient continuously for 24 hours a day, like you do typically whenever you start parenteral nutrition, it obviously can cause complications such as fatty liver disease, as well as biliary sludging and other complications. That is why if you have a risk of developing PN-associated liver disease, particularly for our patients who have been on PN for at least a month, we may actually reduce the total time that we infuse the PN by doing what is called cycling. And cycling essentially is just reducing the total amount of time per day where we give the parenteral nutrition bag. So instead of giving nutrition over 24 hours, we may give it over 18 hours or 16 hours. It just depends on what the patient can tolerate, because essentially we're still giving all of the nutrients that we gave before in the bag, just over a shorter period of time. So you might even have a higher risk of hyperglycemia if you give those nutrients too fast, or you might have some other kind of complication occur, such as, say, if you give them too much fluid over a short period of time. A heart failure patient may not be able to tolerate too much fluid over a short period of time. It just depends on your patient. You may also develop essential fatty acid deficiency as a result of lack of fat, and this particularly happens if your patient is not getting fat emulsion for some reason. So if you think back to the reasons for not getting fat emulsion, think about patients who have high triglycerides, who may be septic, or who may even have an egg allergy of some sort where they can't get soybean oil-based fat emulsion. Metabolic bone disease is a chronic occurrence that occurs when a patient is on parenteral nutrition for long periods of time. And essentially with metabolic bone disease, the reason for that is very complicated and involves multiple factors. One of the most predominating factors is that multivitamin infusion actually only has so much vitamin D incorporated into the formulation, that because of that, you might actually need vitamin D supplementation to adequately combat potential osteoporosis or osteomalacia. There are other issues as well associated with this, such as giving too much protein that can affect your phosphorus and calcium homeostasis. Aluminum toxicity can also affect your bone as well, and that can be a reason why you might get metabolic bone disease. Aluminum may be a contaminant in one of the parenteral nutrition medications that you put into the actual PN bag. So there are many different reasons why you may get metabolic bone disease. But the thing to think about with metabolic bone disease is that it occurs chronically, not acutely. So it takes months and maybe even years in some cases to develop this in some patients. Here is essentially a guide to how we basically go about monitoring parenteral nutrition. I'm going to blow this up and actually put it on a Word document. This is actually taken from v2.0 specifically. I don't want you to necessarily memorize every single one of these for your midterm exam, but you will need to be aware of these labs whenever we start writing parenteral nutrition orders, because it will be very important to keep in mind all of these different lab parameters that are here. This is a sample parenteral nutrition order form that basically talks about all the different components that we talked about today, such as indications for therapy, administration route, which we always check first, essentially the rate and volume that we want to give. If you want to give a cyclic schedule, calculating out your requirements for macronutrients, your electrolyte additives, which can be basically inserted here, insulin, multivitamin trace. If you want to add other additives, such as other vitamins and trace elements, or even medications like famotidine, for example. Those are all basically here on this form. In class, we're actually going to use another form for the purposes of calculations, just to make it a little bit easier for you as you go through and calculate and prescribe your first parenteral nutrition formula. Here are the references for today's talk. And we're going to go back to our case. So we have our 57-year-old female FM who presented to the ED with recurrent nausea and vomiting, probably related to her Crohn's disease that was diagnosed recently. Over the last 2 weeks, she's been reporting feeling weak as a result of poor oral intake secondary to nausea and vomiting symptoms. Abdominal scan findings demonstrated a small bowel obstruction. A PICC line, right peripheral IV line, and nasogastric tube or NG tube were placed. And currently, FM's vitals are within normal limits. So question 1, what type of nutrition is most appropriate for FM to receive? The answer here is central parenteral nutrition. So if we go back to the case, it states that the patient has a PICC line, a right peripheral IV line, and a nasogastric tube. And apparently this patient has had recurrent nausea and vomiting. So it's not likely that your patient is going to tolerate oral nutrition, as she's already had poor oral intake over the last 2 weeks. So basically we can eliminate this answer. We do have a central line for our patient. So essentially we're basically down to these 3 options here. So we have an NG tube, we have a peripheral line for peripheral parenteral nutrition if we choose to do that. And we also have a central line in that we have a PICC line, peripherally inserted central catheter. Now, what makes this a little complicated is that if she has nausea and vomiting, particularly recurrent nausea and vomiting due to poor oral intake, typically I would say drop, an NG tube into her, maybe see how she tolerates, a low amount of feeding. You might even go along the lines of, inserting it further distally into, maybe the jejunum. However, because she has a small bowel obstruction, it's not likely that her nutrition is going to be able to be properly digested and absorbed, depending on where that small bowel obstruction actually is. So this is essentially the factor here that kind of throws everything in a loop. So in that case, I probably wouldn't give this patient enteral nutrition because they already have some kind of obstruction there that needs to be taken care of. And typically those can be taken care of via surgery, and sometimes depending on the size of the small bowel obstruction, it actually might resolve on its own. So now we're down to peripheral and central parenteral nutrition. So remember, peripheral parenteral nutrition is limited by the osmolarity component. So if we want the patient to receive a full nutrition regimen with adequate amount of calories and macronutrients and micronutrients, and if we have a central line, which we do in that we have the PICC line here, we would actually pick central parenteral nutrition for our patient. We wouldn't pick peripheral as basically where we have access to a central line. Now, if we didn't have a central line already placed for our patient, we would probably pick peripheral parenteral nutrition for this patient if we did not have access to a central line. But obviously, central line is preferred if we have access to it, and EN is contraindicated, which it is here because we have a small bowel obstruction. So that is why the answer is CPN. Question 2, when is it most appropriate for FM to receive the nutrition support modality selected in case question 1? The answer here is immediately. And the reason why we will say immediately is because your patient has had recurrent nausea and vomiting. And over the last 2 weeks, she's reported feeling weak as a result of poor oral intake. So you essentially see here that this poor oral intake is causing this patient to feel weak. So that's probably a significant amount of nutrition that the patient is lacking. And if you go back and remember our parameters for determining malnutrition, essentially if you have a reduced energy intake of, basically less than 50% of normal for at least 5 days, or less than 75% of normal for at least 1 month, that can be very problematic and may be a reason why you have malnutrition and potentially a malnourished status. In addition, she already has some other disease states which already predispose her to having a malnourished status, such as Crohn's disease and small bowel obstruction. So as a result of that, if you are malnourished, you always want to feed immediately. And because essentially she is getting central parenteral nutrition, we can start that central parenteral nutrition immediately for this patient. So that is the answer to question number 2, immediately. If she was not malnourished, she would potentially be okay with getting nutrition within 7 days. If she was going to get enteral nutrition and she didn't have a small bowel obstruction and she was able to tolerate some form of enteral nutrition like nasojejunal feeding, for example, I would be okay with within 24 to 48 hours for this patient, or even I would be okay with immediately, because as soon as a nasogastric tube or a nasojejunal tube are placed, you can start feeding immediately after that. Within 10 days is not correct here. So that's why the answer is immediately. Question 3, what's the most likely complication of the type of feeding selected in case question 1, which is central parenteral nutrition? The answer here is infection. So we mentioned infection throughout because the fact of the patient having a central line obviously increases your risk of infection. The fat emulsion component obviously increases your risk of infection. Nausea and vomiting and abdominal distension are adverse effects and complications that you see from enteral nutrition because it's going into the GI tract. So nausea, vomiting, diarrhea, abdominal distension are not complications of parenteral nutrition. Metabolic bone disease, as we mentioned before, is a chronic occurrence of parenteral nutrition that takes months or maybe even years to develop. So it's not likely to occur immediately for this patient. The thing that would potentially occur more acutely and more likely right now is potential infection because of a central line insertion and as a result of potentially getting fat emulsion. If you have any questions regarding parenteral nutrition, please feel free to email me. Thank you and have a